So thank you very much. And I'm going to talk about risk stratification for non-muscle invasive bladder cancer and how it helps in decision-making in 2022. Now we know that NMI bladder cancer is a very heterogeneous disease. And the two problems that we face include the recurrence, and the other problem that we face is progression. So the recurrence potential is between 30 and 80% at 5 years. Progression potential, however, is very variable. It's from 1 to half of the patient that can have a progression. So, so less than 1%, obviously very, very low chances of progression, to up to 45%. The factors which are responsible for these two events is number one, the multiplicity, age, stage, prior recurrence rate, carcinoma in situ, grade, size of the tumor. In one of the models, the Kyoto model, has also used gender as a variable. So over the last 16 years, we had actually 4 different risk calculators. The EORTC 2006, Kyoto 2009, and then we had 2016 EORTC, and then last year the EAU risk calculator was described. So we're going to look at all these 4 models briefly and what was their utility. In 2006, Sylvester et al. Reported the first EORTC risk calculator, and it was patients who were treated in the early 90s, late 70s to late 80s, and patients who had, and the variables were collected from over 1,400 patients treated in 7 EORTC trial. The important factors which were described, and they were categorized into potential for recurrence and potential for progression, were in this Omni calculator. Patient was stratified into low, intermediate, and high risk based upon those prognostic markers. Majority of the patients were treated with intravesical chemotherapy because BCG was not very well established at that time, and only 6% patient had BCG treatment. 1973 grading system was used. 3 years later, Fernandez and Gomez reported in Journal of Urology the Kyoto table or Kyoto model. Now it was based on 1,000 patients' data. 2/3 were primary tumors, and the data was collected from 4 Kyoto trials in the 90s. The impact of BCG was one of the compounding factor in Kyoto trial. BCG was again in the initial phases, the maintenance regime was not clearly defined, and majority of patients actually received 6 induction and few maintenance cycle. Majority were only up to 12 total installations of BCG. Kyoto is the only model which used gender as a risk factor, and female were considered at a higher risk for recurrence than the male gender. In 2021, the over 3,400 patients data was used, this by EAU 2021 model. All of them were primary tumors. The data was between 1990 and 2018, and the majority of the patients were after 2010. Stage of the disease, TA versus T1, carcinoma in situ presence, grade, using the 1973 grading system again. Size and multiplicity and age were important factors. One of the difference between this and the previous model is that they have categorized patients now between low, intermediate, high, and a new category, which is a very high risk patient. Now, why this new category was introduced is because even in the high risk category, the patients behave differently. So some of them have very aggressive cancers, and the other ones have relatively less aggressive cancer and respond to intravaginal treatment alone. The impact of variant histology, primary carcinoma in situ, and recurrent tumors were not added into this model. Now, this is the various parameters and their weightage, which is described on the left-hand side of the table. And if you look at this half, you can see that the probability of progression at 1, 5, and 10 years is very different between high risk and very high risk category. So high risk category, 1 year progression is 3.5%, whereas it can be 16% for very high risk group. Similarly, 5 years, 9.6 versus 40. So 4 times increase in chances of progression between the high and the very high risk. So we now clearly see that high and very high risk are 2 different categories. Let me take you through a few cases, and this is a 67-year-old gentleman who presented with gross painless hematuria for the past 3 months. It was variable in intensity, off and on, which is typical. An ultrasound was done, and the ultrasound showed a small growth in the posterior wall of the bladder, close to the left lateral wall. He had a TUR. The TUR was performed in a piecemeal fashion. It was sent for histology, and the histology showed, as you can see, a high-grade non-muscle invasive bladder cancer. If we plot this patient's data on the EAU 2021 risk calculator, which is available at nmibc.net, the patient's age was less than 67 years, less than 70 years. It was a primary tumor. There were multiple tumors greater than 3 centimeters. The stage was T1. There was no carcinoma in situ, and the grade was high grade. So this patient is categorized as high risk based upon the risk calculator, with 1 year probability of progression at 3.5%, 9.6% at 5 years, and 14% at 10 years. What are the recommendations for treatment of high-risk patient? Well, the current EAU 2021 recommendations in the 2022 guidelines is that patients should be categorized into 4 risk categories, and this is the recommendation from the EAU. You use the 2006 URTC scoring model to predict risk of tumor recurrence in individual patients not treated with BCG, and the recommendation is high. And use the 2016 URTC, or the Kyoto risk, for patients who are being treated with BCG intravaginal immunotherapy. And these models should be used. So again, the recommendations. So in essence, EAU 2021 4 risk groups are low risk, and these are primary single TA, low grade, less than 3 centimeters in patients without CIS, in patients who have who are under 70 years of age. For a primary low grade or G1 cancer with one of the additional clinical risk factors like age greater than 70, or multiple tumors, or tumor diameter of greater than 3 centimeters, stage T1 can also be considered as low risk, but they have to have only one of these categories. High-risk patients are all T1 high-grade cancers without CIS, except for those who are included in the very high risk categories. All CIS patients, except those who are not in very high risk patients, are also considered as high risk patient. So what are the very high risk patients? TA high grade, NCIS with all three other risk factors that we have talked about, T1, G2 NCIS with at least 2 risk factors, T1 high grade with NCIS at least 1 risk factor, and so on. So presence of CIS is added as a risk factor in this and categorized into very high risk category. So patients with tumor in the prostatic urethra, lymphovascular invasion, and variant histology are now included in very high risk categories, and these patients should be treated differently from high risk category. Intermediate risk is more of an exclusion diagnosis, which means that if the patient doesn't belong to any of these categories, they are intermediate risk cancers. Let's see another case, a 68-year-old lady, non-smoker, gross painless hematuria for the past 2 months. Ultrasound showed a tumor on the posterior wall. Cytology ×3 were negative. She underwent a CT scan as well. And TURBT was performed. Arm mass resection was done, and tumor was sent for histopathology. Now, if we look at this lady, she had a single tumor, which is less than 3 centimeters. Her pathology is TA. She does not have any carcinoma in situ, and she had low-grade cancer. So she belongs to a low risk with 1-year progression potential of only 0.06%. So this is really very, very low. And this is low risk patients, and most of them can be treated conservatively with single installation of chemotherapeutic agent. So the EA recommendation for low risk is obviously, this is what the tumor is, and these patients can all well be treated by single installation of chemotherapy. And it significantly reduces the recurrence rate. Progression, as we have seen, is not a significant risk factor for low-risk patient. So a single installation reduces the risk of recurrence and is considered as a standard complete treatment for most patients with low-risk disease. This is a 79-year-old male, diabetic, hypertensive, ischemic heart disease. He had a history of bypass grafting, and he also had a valvular heart disease. He's been on warfarin. He had recurrent gross hematuria. He had an MI about 9 weeks back. Very poor anesthetic risk. Flexicystoscopy was done, which showed a very small, apparently low-grade papillary lesion. Now, because of all his comorbidities and the cardiologist recommending not to stop the anticoagulants at all because of a high risk of very anesthetic, peri-operative MI, this patient underwent only a flexicystoscopy with a little sampling of the tumor. Now, how this patient should further be treated, and this is something that we see in our daily clinical practice. Now, there are 2 important studies on how to deal with patients with very high risk, very low risk cancers with very high anesthetic risk. So this trial by Mustafi et al. Used chemoablation, which means 4 to 6 installation of MMC without regular TURBTs and cystoscopies. And they had a complete response rate in about more than 1/3 of the patients, and which were biopsy proven. Another study by Lindgren and Recioppi, about 60% complete response was observed for visual inspection only, so flexocystoscopy only, that showed no recurrence of disease. In this trials, there was high compliance with very few adverse events. And if you look at the patients, the recurrence-free survival was over 80%. So some of these patients who are very high anesthetic risk can actually be treated very conservatively with chemotherapy alone. What about use of surveillance only for low-risk patients who are high anesthetic risk, low risk from the disease perspective? And these meta-analysis of these various studies, you can see that surveillance is also an option. Beg your pardon. Surveillance is also an option, and in these patients, they were nearly about 1.5 years of follow-up, and the development of NMI BC was seen in less than 1% of the patient. So these low-risk cancers can actually stay there in the bladder, but they would not have any significant impact on disease progression and various other complications. So treatment of intermediate risk patient, again, intermediate risk patient without CIS are the ones which is more of a exclusion diagnosis, so that they don't belong to low, high, and very high risk. They are actually intermediate risk patients. And for intermediate risk patient, repeat chemotherapy installation improve the recurrence-free survival in intermediate risk patients. So chemotherapy suffice in majority of cases, although there are short duration and small dose BCG, which is 1/3 dose or 1/2 dose, can also be given, and there is good quality evidence in favor. But I think BCG should better be reserved for patients who've got high risk or very high risk disease, because BCG shortage is an issue. So induction plus 3 monthly installation for 1 year at 3, 6, and 12 months is what is really recommended for intermediate risk patients. The high and very high risk group is something which we need to look at it more objectively. The major concern is progression to muscle invasive bladder cancer or metastatic disease. The new risk stratification of high versus very high risk is extremely important, because the high risk group was also quite variable. So if we look at the 2022 guidelines and the recommendation for high risk and very high risk patient, for high risk patient, intravesical BCG for 1 to 3 years is what is recommended. Cystoscopy and cytology at 3 months is strongly recommended. If the patient continue to have negative cystoscopies and cytologies for 2 years, then 5-year follow-up is what is, an yearly CTU or IVU is required to look at the disease outside the bladder and the upper tract. For very high risk patients, as we have said, lymphovascular invasion, presence of variant histology, and carcinoma in situ are the ones which need to be primarily counseled for radical cystectomy. And it's very small group which does not agree for cystectomy are the one which need to go for BCG. So what about carcinoma in situ, the primary carcinoma in situ without papillary disease? Well, approximately half of the patients with CIS progress to muscle invasive cancer. The prognostic factors for CIS is concurrent T1 tumors. So T1 and CIS is a much more aggressive disease. CIS in the prostatic urethra, again, or extensive CIS involving most of the bladder, and the initial response to BCG. These are some of the risk factors which define bad versus better CIS patient. So this is another case of 64-year-old male who had gross painless hematuria. He's hypertensive, ischemic heart disease, angioplasty on clopidogrel. His ultrasound and CT are being shown here, and you can see a significant large bladder growth on the posterior and the left lateral wall. He had his TURBT after a lot of risk stratification and optimization. The pathology showed a high-grade papillary urothelial carcinoma, and the lamina propria invasion was present, which means T1 muscularis propria invasion was not seen. So it's a true T1 high-grade cancer. This patient had a re-TURBT, which showed some residual disease, which were resected. There was no upgrading of tumor to T2. So he had induction between April and May last year with BCG. Cytology was done after the induction BCG, which was unremarkable. Surveillance cystoscopy in July was also unremarkable. However, the subsequent cystoscopy showed a high-grade papillary urothelial carcinoma, which has recurred, and lamina propria invasion was not present. So it's a TA high-grade recurrence, which is again following induction BCG therapy. Options were discussed with him, including radical cystectomy at that time, but because of the very poor cardiac risk, it was deferred, and he was started off with reinduction followed by maintenance therapy. However, unfortunately, a couple of weeks back, he presented with weakness in his leg. His bone scan indicated multiple bony metastases. His PSA was normal. We were seeing that there may be a concomitant prostate cancer. However, it was bladder cancer, which has the CT cap was done. And as you can see, there is a lesion in the lung. There are multiple lesions in the liver, and he is going palliative chemotherapy. So radical cystectomy for very high-risk bladder cancer should be done earlier than later. There is a good argument for radical cystectomy for a very high-risk patient because there is a chances of upgrading tumor after on cystectomy for NMI BC, high-risk bladder cancer. Although there are some risk of cystectomy, which include poor quality of life, but again, a delay in radical cystectomy can give you a much worse overall prognosis than for in situ for de novo T2 cancers. So my acknowledgements to the EAU 2020 guidelines and a Euro webinar on patient risk stratification. I'll be happy to take questions, and we will be soon having a post-test based upon the 3 presentations that we have. Thank you very much.